Vishnu, can you start?
Am I audible? Hello?
Yes.
Yes, Vishnu.
So good evening all. Welcome. I heartily welcome everyone for the academic session of Spice Route Kerala team. After a long time, we are having a academic meeting. So we are having one eminent speaker who is an ardent practitioner for having who is delivering the talk today, and the session will be moderated by Roby Madam. She is a consultant family physician at Roby's Family Clinic at Kozhikode, and the speaker for the day is Dr. Ali Zameel. He is a consultant family physician at Mitra Care Clinic. And before starting the meeting, I would like to welcome all the participants, teachers, and postgraduates who have found time to join this meeting. And over to the chairperson. Roby Madam, you can take over the meeting.
Good evening, all. First of all, I would like to thank the Spice Route members for inviting me to this meeting and being part of such a wonderful topic of family medicine. Ali is a good friend of mine, and I just saw his second slide showing my story, and I believe that is exactly what we're all here to discuss. We're all here to discuss about our own practice and what we should be doing in our day-to-day family medicine practice. So each one of our stories are a perfect thing to be discussed in this topic. So Ali, I think it's time you take over the topic. All the junior, I think many junior doctors are participating in this meeting. So I hope it will be helpful to each one of you. Over to you, Ali.
Hello, am I audible?
Yeah, you can carry on, Ali.
Yeah.
You're audible, yes.
Everyone. Actually, when we thought of starting the first session for Spice Route Kerala this time, once the Nadeem stepped down and handed over the reins to me, I thought this would be a nice way to start. Probably, because Spice Route is, as Dr. Serin always says, is an informal part of AFPI rather. So it's where we can discuss what happens in our lives, what we do, and connect with each other and support each other and grow together. So I would also, like to make this session informal as well. Start with the session as an informal session in the sense. So anybody would like to ask something in between, please feel free to interrupt me and ask anything. So without much ado, I think I'll start the session. So good evening, everyone. And I'm thankful to have this opportunity to present this topic, actually. So first, I thought before discussing what I do in my day-to-day practice, I thought I'll give a brief introduction about myself, how I got into family medicine, and how I developed the interest in family medicine, and how I reached here. So this is my journey. It may not be that inspiring and all, but I thought probably this is the way we can get closer to each other and start helping each other. So I've graduated from KSAK Medical Academy in the year 2009. And as always, after MBBS, it's a question mark. So what to do next? What to do next? So in my batch, I was, I can say, maybe average would be above average person. So, but in the sense, I was not so much into the entrance exam orientation. So I always, we always think of an easy way out. So at that time, back in 2009, the easiest way out was rather than slogging for the entrance exam was to give the DNB entrance exam. And that time we just had to qualify, that is get 50%. And then you apply to the hospitals and you could join any specialty. So what more than that, so easy. So we thought, okay, me and my friend got together and we got this preparatory book for that. And then luckily or fortunately we cracked and we got 50%. So we applied in different hospitals throughout, in Karnataka and Kerala. So I was interested in internal medicine. So I applied for internal medicine. But then that time DNB was not recognized by the MCI. So unfortunately, during that time itself, MCI begins to recognize DNB. And so we were not allowed to join immediately. So there was a huge delay around, I guess, 8 months. So every 6 months, DNB entrance exam used to be there. So after us, there was another batch who wrote the exam. And finally, they said that, DNB is recognized by MCI. So you have to, you can only join the course after a proper counseling is done. So then we are, I guess, around 2 batches, we are allotted the counseling session. And finally, because 2 batches were together, I did not have a good rank. So I ended up in Delhi for the counseling. And then I was given 3 options: family medicine, psychiatry, and physical medicine rehabilitation. Back then, I did not know what PMR was. Psychiatry was not my choice. And family medicine, I thought it's closer to internal medicine. So I thought, okay, probably, I'll go with that. So I selected family medicine. I opted for family medicine. I tried to get my allotment letter, but since it is, pretty old, I lost it somewhere. Sorry. So I got family medicine, DNB family medicine at St. Martha's, Bangalore. And as all of us know now, it's one of the best institutes. But then back then, I was a fool. Probably I did not know. So on my way from Delhi to Bangalore, I spoke to my friends. And to say that out of 100 students in my batch, none of them have taken family medicine. I'm the only person. And probably in my immediate senior batch as well. So family medicine was something really new. And there was not one person whom I knew who has done family medicine. So I called up my friends and they said, you see, don't make this kind of idiotic mistakes joining family medicine. You don't know what's going to be your future. Family medicine is something really new in India. And DNB is also just recognized. So you want to take up DNB and all those things came up. So I was in a dilemma. And then I thought, okay, fine, let's see what happens in future. And I dropped. And that was probably one of my, I can say, biggest mistakes in my career. That's why that emoji over there. So, and then what happened is that I thought, I have to move forward. So again, I was interested in medicine. So I thought I joined as a registrar in internal medicine at Dhanlakshmi Hospital, Kannur. So, and then since I was not so much focused into entrance, I used to give the exams here and there. And then by 2012, there was so much pressure. I was married in 2010. So there was a lot of pressure on me to do some PG. It's obviously, as you all know, once you finish MBBS, it's all about doing some PG. It doesn't matter what you do, some MD they want. So I was under that pressure. So going back, I had given the entrance exam at NITY as well. And so they called me and I was given 3 options. I had pathology, anesthesia, and community medicine. Now, again, I was not much interested in community medicine. And I was also, again, not aware what, PGs do during community medicine. So, but then it sounded somewhat closer to medicine. This is just like how I took a family medicine, which was closer to internal medicine. So I thought, anyway, there is some medicine. So once I do, at least I'll be an MD, I can practice. I don't know what, I'm not interested in teaching and all that. So that's how after 2012, I joined for community medicine at KSEC Day itself. So my alma mater. So 2012 to 2015. So once I joined, the first day I wanted to know was, what do they teach in community medicine? So I wanted to get the curriculum, but then since it was relatively new, a new course in our college, so the curriculum, and it is a deemed university by then. During my UG, it was not a deemed university. So what happened was I wanted to find out where the curriculum was. We got the curriculum and then realized that, there are around 6 months of postings in various departments, rotatory postings, and then you have around 6 months of rural postings in the health center and 6 months of urban postings in an urban health center. So once this, I got to see this, I was like, this is somewhat closer to family medicine, because I had gone through the curriculum. So I thought probably, I can convert this course into a family medicine sort of, because that is something some sort of, blunder that I made. So I wanted to get back somehow. So that is my aim. So once I joined community medicine, the sole aim was to get into family medicine. So we went to the HOD, we spoke to him, we bugged him literally. And then finally he agreed to, give us the postings as per the curriculum. So that is how my community medicine PG went. I utilized it rather than learning community medicine. I think I was learning family medicine also, probably at least 30 to 40%. But then I did have some bitter experience as well. I remember when I joined for community medicine, there were a lot of doctors who made fun of me. There were a lot of seniors. There were a lot of professors actually who said, community medicine and this is not done. Why do you want to take up? Somebody was like, this is what people look at, so these are doctors who look at sewage systems and things like that. There were people in the family itself, who made, who actually, gave us smirk all the time. So, but then I didn't bother, because my aim was not to, stay in community medicine. So once that was done, I searched for the course during community medicine itself. So immediately once I finished my community medicine, I joined for the PG diploma of family medicine from CMC Vellore. And that was actually one of the turning points in my life as far as family medicine is concerned. So I again got a real taste of what family medicine really is. And we had good mentors from the UK who were practicing in the NHS, two doctors, great doctors, and who actually sensitized us to what family medicine is, how you really do a consultation, how you really approach patients, and how to diagnose, rather than what we typically do in the Indian system, where, it's all about prescribing some medications and getting off to the next patient. So patient-centric medicine was really learned through family medicine from CMC Vellore. And I'm really thankful to all those who helped me over there, including my mentors. So, and I was lucky enough to secure the first rank as well. So, and then in 2015, actually, once I finished my community medicine, I joined KMCT Medical College. And there again, I was fortunate enough to be joined as the medical officer in charge of the health center, which you can see over here. So this is actually a house which has been converted into an urban health center overnight for MCI inspection. And fortunately, this inspection was 2-3 months after I joined the college. So I was again fortunate enough to join there as a medical officer. So I was running the OP and managing the health center. From 2015 to 2020, I was there. So 1 year after joining the health center and running the OP, we had a decent number of patients, and probably the management, realized something. And then one fine day they called me and they said, why don't you sit in an evening OP? We don't have doctors in the evening, physicians in the evening at the hospital. So why don't you come and, sit in the OP? So I was the first doctor to represent family medicine at KMCT Medical College Hospital. And again, I was lucky enough to, for that. So I used to run the evening OP at the hospital as well. So, and then this is basically what I, did at KMCT. So there were house surgeons who were actually posted with me at the health center for around 2 weeks. So whatever I learned in family medicine, I just, transferred it to them. So I thought teaching is the best way to learn again. So again, here is, me giving a lecture on orientation in family medicine. Now, this was towards the end of 2020, before I left KMCT. So that is my experience so far. And then I thought, PG diploma is still not enough. So all these people with DNB, so I thought, I need to do something more, and also I need to learn more. So then I thought, what is the next thing? So MRCGP came up, and that is where I met all these wonderful people. That is Dr. Roby, Dr. Shobha, Dr. Anupama, Dr. Jyotika, and everybody, Dr. Anup, everybody. And during the academic sessions we had prior to the exam, that's the first time I met all these people, wonderful people. And they have actually handheld me and helped me in a number of ways in my practice as well, especially Dr. Roby. who actually, I guess, is also somewhat like me in a way, because she's done internal medicine and then she's taken up family medicine. And she used to support me a lot when I had, queries. I used to call her in the middle of the night, even, asking about some patients and things like that, what to do next. So, yeah. And so finally, I left after 5 years. I thought it was high time, in an institution. So I thought I need to move on. And then I need to move on into solely family medicine practice. And that's when I applied for a post at Mitra Hospital. And actually, Dr. Vijay does have a role in me joining there. And so he called me up, and then he spoke to me regarding this clinic that was coming up in Kasaragod. And he said, it is all about family medicine, centric, and probably, you can do something there. So that's how I joined Mitra Hospital. I'm not going into the details of how the thing was set up and things like that. Probably, if anybody's interested, they can ask me. I can answer later, because I guess this would take up a lot of time. So in the initial phase of setting up the clinic, Dr. Vijay had a major role as well. So yeah, so this is what I do now. So ours is actually a comprehensive care clinic. The idea was to set up the one of a kind comprehensive care clinic at Kasaragod, and the idea was to give comprehensive care. So comprehensive care in the sense, just having a doctor or a nurse or a supporting staff won't be enough. So we thought, what could be added to family medicine? So we had departments which were actually supportive to family medicine. That is physiotherapy, psychology, physiotherapy and psychology mainly. And then we had planned, other services which are related to family medicine. So this is my team at Mitra Care Clinic. So there are totally around 18 to 20 of us. All the members are not here in this picture. So we have 2 physiotherapists, 3 nurses, 2 lab technicians, 2 pharmacists, a PCS staff, a receptionist. We have a business manager now who's recently joined. We have 1 GDA, 2 housekeeping staff, a supervisor. We have Mitra has a heart center as well nearby. So the supervisor manages both. We have a maintenance person. We have a vehicle and a driver, a security, and 2 marketing person who is, these marketing people work for both the clinic and the heart center as well. So this is my team. The first thing, the first picture, why I put the team picture is that because I feel that any organization, be it a clinic, a hospital, or anything, be it a shop, it is not the infrastructure or the facilities that this matters. It is always a team that matters, and teamwork ultimately leads to success. So that's why I put in our team's picture first. So the services that we provide at a clinic is obviously family medicine. We have physiotherapy, psychology. We do have specialists coming in on and off. We have orthopedicians coming every week. We have neurologists coming in twice in a month. And the other specialty is telemedicine. So I'll be talking about it later. Then we have allied services, pharmacy, laboratory, and we also provide home care. So this is how we, ultimately give comprehensive care by providing all these services together and ensure that patients get continuum of care. So this is a typical workflow. So the patient enters a facility. They undergo triage where, non-emergent and emergent patients, they are identified. So those in an emergency, they are taken to the procedure room and they are given the treatment over there. The nurses do give the initial care. For example, if somebody with a high blood pressure, so they give them the stat medications. They ask them to get the ECG done, and all those things are done by the nurses itself. So somebody has a high temperature, so those people are taken care of. And then those non-stable, non-emergent patients, so they are escorted to the reception. Once the registration is done, so then they undergo an assessment by the nurses. Then they're taken to the consultation room. Once the consultation is done, they either go to the lab, the pharmacy, the physiotherapy department, psychology, and then before leaving, they also give feedback. So this is a typical workflow in our setup. And this is also a typical consultation, which most of us are doing. I just, mentioned it here. So my consultation usually for a new patient, is around 20 to 25 minutes. I know it's probably too long, especially those who are working in the government sector will be like, oh my God. So yeah, we do have the privilege of doing that, especially in this kind of setup, because I don't get 50 to 100 patients in a day. So my patients are limited to around 30, 35 OP in a day. So I have enough time. So I spend time with my patients. Again, family medicine is something new to Kasaragod, where I'm working. So since Kasaragod is, lacking in healthcare, that was one of the reasons why Kasaragod was chosen for this project. So here there are a lot of things. I'm sure that those who are working in different areas will realize that the geography, the community related to that geography, all matters as far as a typical practice is concerned. So the people are different. So I used to work in Calicut before. The people are different there. Here, the culture is totally different. There's a lot of lack of health literacy. So people don't know about, health conditions at all. They're not concerned about their health at all. I mean, majority of them. So a lot of things, a lot of challenges that we faced. It was a typical consultation where we greet the patient. If I'm taking too much time, I mean, please let me know so that we can move on to the case presentation. Huh? If it's boring also, please let me know. So the typical question is, in Malayalam, I ask, Endipatti or what happened or how are you today or what brings you here. So then they open up. So then based on that, I take a focus history, do a focused examination, and usually some people say you need to break the ice early. That is ideas, concerns, and expectations. But I try to take a bit of time, understand what's going on here, and then I ask what are the, I try to get out what are the ideas the patient has and concerns and their expectations regarding this. Then, so by then, probably I would have had a diagnosis or a provisional diagnosis. So I explain to them what it could be or what it is. So, or what are the tests that need to be done and why it needs to be done. And then the appropriate treatment, drugs or whatever it is. And then I ask them when they have to come for review, and also safety netting as always, which is very important. So this is my typical consultation. I mean, all of us are doing the same. Yeah. So moving on, typical day in my practice. So I see, fortunately, I'm able to, get all spectrum of patients from pediatrics to geriatrics. And then we do get good emergencies. Yeah, may not be those complex ones, but we do get RTAs. We do get dyslipidemias related to renal failure and things like that. We do get acute MIs, chest pain and things like that. So good enough, I can say. And then I do perform minor surgical procedures, aspirations, intra-articular injections, cyst excisions, plasties, and so on. So I actually, as I said earlier, I had gone through the curriculum of DNB family medicine, and since I had not done DNB family medicine, I wanted to cover most of the things that are supposed to be done by a family medicine doctor. So I used to take the curriculum and just use it like a checklist. Okay, I've learned this, I've done this, and things. There is still many more things to do and learn. So another thing that is quite relevant in my practice is the telemedicine. So we have a telemedicine unit that is a device which is imported from the US. So it's a device-assisted telemedicine unit. So we have devices like the ophthalmoscope, the otoscope, the dermoscope, the spirometer, and obviously the vitals monitor, which includes the ECG, saturation monitor, temperature, and so on. So this thing actually is quite important because, as you all know, family medicine practice, it's not you need to be always licensed with the other specialities. So this actually helps me in a way, in a lot of ways, in the sense that even though without having these specialist doctors around me, they're always, a call away. So that also gives me the confidence to, treat my patients. So any patient, whom I feel requires a specialist consultation or super specialty consultation, I get a teleconsultation booking done for them, or they take it whenever they want. and then the teleconsultation is done, and the follow-up care is done by me. So it also helps me in understanding how these specialists work, what are the medicines they prescribe, what are the guidelines they're following, and also helps me gain more insight or knowledge into these kind of things as well. So this is a ophthalmoscope. It's actually pretty easy to use compared to the normal ophthalmoscope that we use, the non-digital one. So here it is. Once you get the hang of it, yeah, initially it's a bit difficult to get the fundus focused, but once you get the hang of it, then it becomes easier. Without dilatation itself, you can view the fundus. So then we have the otoscope as well. Yeah, all small things, but the other is obviously family medicine or general practice is incomplete without going home to the patients or giving house visits and also performing outreach activities. So we do conduct camps and other awareness talks and other activities. We do have home care. So even today I had visited a patient at home. So, and also, doing all these things, all these multiple things makes me happy and, feel that, this is what real family medicine is all about. And even if today, somebody says, you take up, see, I'll give you a free seat in cardiology or gastroenterology, I wouldn't take it. So because family medicine is, I feel, personally, is one of the most challenging specialities because, 1 minute you see pediatric patients, you treat them with ARI. The next minute you are seeing an ENT case with nasal polyps. The next minute you see a hypertensive emergency. The next minute you see something else. So it's always a challenge, and that's what keeps me interested. And I'm pretty sure that all of you feel the same way about family medicine. And again, family medicine is also one specialty where the what can I say? Burnout is also pretty high. So since we are in the front line, so yeah. So again, so it's not just all about work. So we also, it's work hard and party harder. So we also have a bit of fun at the clinic when we are free, also outside. And as I said earlier, keeping the team together is very important. Understanding the dynamics is very important. And without the team, I'm nobody actually. So without my team, I'm a big zero, I can say. So it's my nurses, it's my other staff around me who actually support me and ultimately gives patients the satisfaction. So to conclude this part, so I hope I'm not taking a lot of time. So family medicine is definitely a specialty with no limits. There is every other day since I guess recently this counseling and all was going on, I used to get calls from my students, ex-students from KMCT. So they used to call and ask me, so I might get diploma family medicine. Shall I take it up? What is your opinion? So I have gotten at least around 10 to 15 calls this counseling session. So, and every student, I have told them without doubt, definitely close your eyes and take up family medicine because this is the way to go and this is the future. So, and there is no limits because you can focus in any specialty that you want. Yeah. Opportunities are abundant, as we all know. And obviously the right attitude and the willingness to learn always is pretty important. And I also believe that family medicine is closer to communities than other specialties because that's the way we work. I believe that tertiary care hospital or a quaternary care hospital may not be the ideal place for a family medicine physician. So probably a nursing home setup or a clinic or even a secondary care hospital at the most would be a place where family medicine physicians would work ideally. So that is my thinking. So please share your views as well. And family medicine is all about patient-centric comprehensive care. The motto that I learned from CMC Vellore is always refer less and resolve more. And yeah, what about a competition? I would say the competition is none but we ourselves. So for me, I'm my competition. So I need to always up my game and, upgrade my knowledge and try to give the best to my patients. So with this, I would like to conclude the first part of the session. And the next is a case presentation. So if anybody wants to, share their opinions or ask me something, please feel free. I hope I've not bored you with this stupid story of mine. Hello?
It's nice to hear your story, Ali. It's really inspiring. Don't say it's not inspiring. It must have inspired at least a few of the juniors who are attending the meeting. And nice to see you working in such a good setup. I guess the difference between I had to run a small clinic, but the difference is that the staff number of staff I have is very limited. I don't have nurses. I just have a pharmacy and a lab which is outsourced. So working in a setup that you have, I think there are so many things that you can do extra than I do in my clinic, because I don't do procedures much. Small procedures, of course, I can do, but and emergencies as well, because I don't have an IP facility. So like you manage this dyslexemias and all that, I am not able to do it. So I think working in a setup like yours is really something that every family physician can dream of. Like that is a dream come true actually for many of us. It's really nice to hear you speak. So if there are anybody has something to discuss, please share your views. You can ask before going to the case. I think you can have a small discussion on this.
Yeah, I guess so. The case review will probably take around 10 to 15 minutes. So my idea was to wrap in 45 minutes. So
you can go. You can continue with the case presentation. We'll have a discussion at last. In the end, we'll have a discussion. Okay.
Sure. Thank you. This is just a small case. So recently we had, not recently, this was 1.5 years back. So sorry. So we had a 50-year-old lady who had visited a physician nearby with shoulder pain, and on investigation, she was found to have HB of 18.8, a total count of 18,530, and platelet of 7.21 lakhs. And the physician from where she had visited prescribed her paracetamol for a shoulder pain and suggested further testing and referred her to a hematologist. So she visited a clinic with the above report. By then, the shoulder pain had slightly reduced. She was anxious as she felt there was something sinister going on because of the referral. So in her past history, she had no history of stroke, cardiovascular disease, coronary artery disease, hypertension, diabetes, or tuberculosis. There was nothing significant in her family. And obstetric gynec history, she was having oligomenorrhea. Probably she was 50-year-old, so probably approaching menopause. So on general physical examination, vitals were, the blood pressure was 140/80, pulse rate was 94, respiratory rate was 20, temperature was normal, and BMI was 23, and saturation was normal. ENT examination was unremarkable. Cardiovascular system was also within normal limits. Respiratory system as well, and a basic central neurological examination was also within normal limits. So on abdominal examination, again, was within normal limits, and all peripheral pulses were felt. So we repeated her CBC from a clinic, and this is the report here. So you can see HB is, HB is 17.5, I guess. It's not clear. There's something covering that part. So 16,600 total count. Platelet is around 10 lakhs. RBC was 8 million. The hematocrit was 57. And the other parameters as shown below. So by now, I guess most of you would have recognized where this is going. So anybody would like to say something? I thought make it interactive. Okay, so I'll just carry on. So seeing this picture, it was leading somewhere, and so obviously we sent for JAK2 V617F mutation, and it came back positive. So the results were discussed with the hemato-oncologist, and the patient had booked tele consultation. So, and this patient was diagnosed as polycythemia vera. So once the teleconsultation was done, so the continuing care and the follow-up was managed by me. So the condition was explained to the patient. She was there along with her husband and her daughter as well. And so what we started was the standard protocol, that is phlebotomy. So that day we did around 350 ml stat, and this was supposed to be repeated after 1 week. The idea was to keep the hematocrit below 44%. So until then, we had to repeat the phlebotomy weekly. So usually phlebotomy is done between 250 and 500 ml, depending on the hematocrit. So once the hematocrit was below 45%, the idea was to repeat the full blood count every 2 weeks, and then do the needful. And we also started her on hydroxyurea, 500 milligrams twice daily. So it was given for a month, and the dose was supposed to be titrated as per her CBC reports. And she was also put on ecosprin, 75 milligram once daily for a month, and also febuxostat, 40 milligrams. So this was the treatment that was given. So we repeated the CBC after 1 week, and the HP was again 16. Total count had come down. Platelet had come down slightly. RBC count again come down slightly. PCV was still 52. So again, we did the phlebotomy. Around 350 ml was removed, and repeated the same every week until her hematocrit came down, and then phlebotomy was stopped, and she was only on medications. So after around 2 months, she presented with this. This is not her picture. I unfortunately didn't take a picture that time. So this is from the web. So, but it was something exactly similar to this. So she had discoloration or pigmentation of both the nails of the hands and the feet. So any guesses what this could be due to?
Juniors can make a try. Anybody? Come on.
Hydroxyurea.
Yeah. It's due to hydroxyurea.
Exactly. Yeah. So this is the blood count 6 months post treatment initiation. So her HB has come down. Total count is within normal limits. Platelet again within normal limits. RBC within normal limits. So hematocrit was around 30. So since she was experiencing minor side effects, so we discussed with the hematologist, and then the hydroxyurea was brought down to 500 milligrams once daily. So we went on like that, and I used to monitor her. So apart from the first consultation she had with the hematologist, the other regular follow-up for the last 1 year, she was under me. So once the hematocrit came down, so we put her on hydroxyurea once daily. The thing was, I used to follow her up regularly. So then the period of follow-up extended in a sense. So once she was stable, I asked her to come once in a month, then once in 2 months. Then recently what happened is that, as I've been noticing, the hematocrit started slowly rising again. So once again, it reached 46. I put her back on hydroxyurea twice daily. So recently now, I guess a couple of weeks back, her hematocrit was 46, and I've started hydroxyurea twice daily again. So I've asked her to come after 2 weeks. So waiting for the review. So this is about the case. So currently she's on these medications. So I've actually put her back on hydroxyurea 500 milligrams twice daily. So moving on to discuss about polycythemia vera. So as we all know, it's a stem cell disorder, which is characterized as panhypoplastic, malignant, neoplastic marrow disorder. So basically the 3 cell lines are affected. So you have increased red cell mass, increased white cell and platelet count. The peak incidence is between 50 and 70 years. So some studies say that there is male preponderance, other studies say that there is female preponderance. The signs and symptoms usually seen headache, dizziness, vertigo. Now, to say this patient did not have any of these symptoms, she only had the shoulder pain. Actually, now she doesn't have that anymore. It is subsided. So these are the usual symptoms that we see. Bleeding complications can be seen in a minority of patients. Epistaxis, gum bleeding, ecchymosis, GI bleeding. Thrombotic complications, again, due to the thrombotic state. There can be venous thrombosis, arterial thrombosis, which can lead to stroke, pulmonary embolism, and so on. There can be abdominal pain due to peptic ulcer disease because there is increased histamine levels and gastric acidity in this condition. Or there could be an inferior vena cava block, which can lead to Buchier syndrome, or abdominal pain can be due to mesenteric vein thrombosis. So the physical findings, again, one thing I forgot to mention, ultrasound was done in this patient. On examination, we did not have any finding, abdominal finding. Ultrasound was done. Again, ultrasound was normal. So fortunately, she did not have splenomegaly, which is usually seen in majority of patients. Actually, we had one more patient, a lady as well. So she had actually splenomegaly. She had hepatosplenomegaly. And the thing was, she was a diabetic patient. She was a little older, around 65 years. But the thing was, we started hydroxyurea in that patient, but she could not tolerate it. So after 2-3 weeks of treatment, she came with ulceration on her leg, and she had severe itching, pruritus, and so we had to stop the medication for a while. We tried alternate day therapy. She couldn't tolerate that. So she had stopped medication for a long time. Recently, she came back. I put her on at least, give the medication once in 3 days. So after that, she hasn't come back for review yet. So there can be other physical findings. There can be a ruddy complexion to the skin and mucosa. Hypertension could be one of the presenting symptoms or signs. So as we move on to the diagnosis, the WHO has given the revised criteria. So either all of the major criteria or the first 2 major and the minor criteria should suffice. So that is major criteria, that is hemoglobin more than 16.5 in men, 16 or more than 16 in women, or a hematocrit of more than 49 in men and 48 in women, and a red cell mass, which is usually not done in most places. It is a radio-labeled assay. So bone marrow biopsy, again, in this patient, we did not do bone marrow biopsy because it was not required. So bone marrow biopsy usually shows hypercellularity for age with the panmyelosis and presence of the JAK2 mutation. So minor criteria is the erythropoietin level is usually low below the reference range in these patients. So again, I was saying, biopsy was not done. So bone marrow biopsy is not required in patients who have sustained absolute erythrocytosis. So that's what we had seen in this patient. Laboratory investigations, again, usually if you look at a smear, RBCs are usually normocytic and normochromic. There is thrombocytosis. We did not do a leukocyte alkaline phosphatase score, which is usually elevated. White cell counts are obviously raised. Hyperuricemia, again, due to increased cell turnover. Again, once we start hydroxyurea to counter that, that is why we have given febuxostat. So, bone marrow we already discussed. USC, obviously, look for hepatosplenomegaly. As far as the management is concerned, the goals of treatment is to reduce the risk of thrombosis, prevent bleeding events, and these patients have a risk of transformation to AML and also myelofibrosis. There are some studies which say that hydroxyurea itself could be responsible for transition into AML. So there is some conflicting studies on that. And to also eliminate the symptom burden. So basically, it's performing phlebotomy to bring the hematocrit down to less than 45%. Aspirin, obviously we know why. Cytoreductive therapy in the form of hydroxyurea and others, and also splenectomy in certain patients. So basically, the pathophysiology, majority of these patients have a JAK2 mutation. So if it is not the V16F, we do have exon mutations. So that is if that is absent and EPO level is low, so we need to test for JAK2, exon 12 and 13 mutations, which is seen in 2 to 3%, very small percentage of polycythemia vera patients. So if the JAK2 mutations are negative and the EPO is normal or high, then we have to think of secondary erythrocytosis. So these are the medications which is usually given. Hydroxyurea is the most common used drug. So if it is not tolerated, interferon alpha, again, that is expensive. There are side effects are more. Busulfan, again, higher chance of these patients developing AML later. So it's reserved for patients older than 65 years who do not tolerate hydroxyurea. Ruxolitinib is another one, again, pretty expensive. So this is considered now as the alternative to hydroxyurea than the other drugs. So hydroxyurea is basically antimetabolite. So it inhibits DNA synthesis and basically brings down cell replication, and that's how it brings the blood count to the normal levels. So the usual dose is 500 milligrams twice daily. Side effects, obviously, it can lead to neutropenia, it can lead to infections, viral infections, bacterial infections. In my patient, I had not seen any of these. Thrombocytopenia, vitamin deficiencies, hyperuricemia. Yeah, one time her uric acid was elevated, otherwise it was normal. And yeah, obviously she was on febuxostat as well. The contraindications is hypersensitivity to this medication. If the patient is having severe anemia or severe bone marrow depression, if the patient is having a white cell count that is less than 2,500, platelets less than 100,000, and pregnancy and lactation are contraindications to start on hydroxyurea. So these patients would need recurrent phlebotomies. As far as the long-term prognosis is concerned, the risk is always there, especially beyond 5 years, to progress to AML and myelofibrosis. The major causes of morbidity and mortality in these patients are hemorrhagic or thrombotic events. So it could be pulmonary embolism, renal failure due to renal artery thrombosis, mesenteric thrombosis, or peripheral arterial disease, which can lead to cutaneous vasculitis sort of syndrome. Hemorrhage in the form of peptic ulcer, a disease, myelofibrosis, and so on. So basically, to follow up these patients is to ensure that the counts are within normal limits, they do not develop thrombotic complications, and ultimately put them on a maintenance regime. Most of these patients are on hydroxyurea for years together, probably 5 and 10 years together. Some of them may later develop AML. So then treatment modalities would have to be changed. And mortality is also beyond 15 years is around 30%. And these are most of the things that I would like to share about my case and the condition. So that brings me to the end of the session. And thank you all for patient listening. So I guess if you have any queries or anything, please, or you can share your ideas or views as well.
It was a very good case, Ali. Polycythemia, we do come across such cases in our practice. And the key point is that whenever patients come with aches and pains like this, it is better always when it's not resolving to look at the counts and also to rule out inflammatory arthritis and all that. So just not to take everything as periarthritis or anything like that. So it's always, even when patients come with knee joint pains, don't take everything as osteoarthritis. You have to rule out all these like hematological malignancies and inflammatory arthritis. So it's always better to do a blood count if the patient is not improving. So anybody has any doubts or want any discussion? I think there are a few questions in your chat box. You can just go through it. One thing, Ali, I just noticed in the blood counts that you projected in the screen is that when your counts were very high, the mean corpuscular volume, the MCV was actually very low. It was around 65. And once the counts improved, it has actually gone to that megaloblastic, not exactly megaloblastic, but it is actually more than 100.
Yeah,
so
yeah,
she must be going in for some deficiencies and all that, which you will have to take care.
Yeah, actually, sorry to interrupt. Hydroxyurea. So it is usually seen in most patients on hydroxyurea. So we had discussed with them, and so we did not do anything further. So these patients, even if the HB goes down, we're not supposed to load them with iron as well.
Yeah.
So,
no, instead of iron, I think folic acid supplements a little bit, and that maybe might help. I don't know if that is also contraindicated. Like folic acid supplementation is not allowed. Iron is not to be overloaded. That is true. That is definitely true.
So this thing was discussed.
The other supplements.
Yeah. So what you and also literature says that hydroxyurea is known to cause macrocytosis.
Yeah, that's right. So that's very prominently it is seen in that the blood counts. It was 65 earlier, and it's more than 100 in the later ones. Right. So anybody? I think there are few questions for you in the chat box, Ali.
One question is first question is sir, the details of MRCGP. Is it a series of tests?
Yeah.
I don't know if this is a right place, but MRCGP, there are two parts. There is a written exam as well as there is a clinical OSCE exam as well. So now you have centers in India, and for the OSCEs, it is either Sri Lanka or Pakistan. So I think that clears that. So the other question is, can you explain how you do phlebotomy? So basically, our certain system, the corporate setup. So the blood bank at Maitra Hospital have to issue the blood bag. So we have kept, since we have a couple of these patients, not couple. So we have 3 or 4 patients in follow-up who are actually doing regular phlebotomies. So we get blood bank actually supplies us with the blood bag for removing the blood. So it is just like any normal venesection for for normal investigation of we draw blood. So this is kept into the phlebotomy bag. The blood is removed and stored in the phlebotomy bag.
Actually, you need the support of the blood bank to do a phlebotomy. It is not possible for us to do it in our OPDs. So definitely you need a support of the blood bank, and that blood is discarded. It's not used for anything. It is discarded actually.
Discarded.
Can you explain? Hello, can you hear?
Hello.
Yes, Jitin. Jitin, you can ask a question, Jitin. You're audible. You can just unmute and ask.
Hello, can you hear now?
Yes, Jitin. Yes, go on with it.
Which vein we will select for phlebotomy usually? Any idea regarding this?
Which vein?
Yes.
Hello.
Yes. Yes.
We use the cubital vein. Hello.
Yeah, thank you. In lower limb, any vein we will use?
Actually, this is the usual protocol in the clinic. I guess other veins can. I don't think there is any contraindication to that.
Okay.
Normally, we do in the cubital vein. You use. I've never seen anybody doing in the lower limb.
Yeah, but I think, technically,
in case some access problem is there, probably you might be able to go from some other places as well.
Yeah.
Is there any role for a folic acid tablet?
Folic acid tablet, there is no indication to give folic acid tablet unless we are suspecting any deficiency. So as I said earlier, the macrocytosis picture that you have seen in the complete blood count, that is the MCV going to around 108. Initially, it was a hypochromic picture when she came to us. Then it actually normalized, and then it went to a macrocytic picture. That macrocytosis is basically due to hydroxyurea. So unless we confirm there is a deficiency by testing, I don't think it is recommended, and that is what the hemato-oncologist suggested as well. So any more questions?
Sir, this 45% of cutoff of PCV is common for both primary and secondary polycythemia.
So that is the standard protocol. See, the idea is to keep it below 45%. So basically, it's to avoid all thrombotic complications. Fortunately, our patients did not have any complications so far. There is, as I said, there is one patient who is not on medication, but I have put her on aspirin at least. So yeah.
The criteria is mostly to decide about whether phlebotomy is needed and all that. I think secondary polycythemia, when you treat the cause, then the patient might not need phlebotomy later on, right? Only in primary, once you need recurrent phlebotomies. So automatically the hematocrit will come down when you treat the secondary cause.
Those are actually basically relative polycythemia, where probably due to plasma volume reduction, you have a relative, it just kind of really fools you.
Ali, there's a question for you from Rashmi ma'am in your chat box.
In a few sentences, could you please sum up your advice to the family residents and young practitioners? Yeah, sure. So without prolonging this further, I would like to say that family medicine is one of the best specialties ever. So I don't intend to, downgrade or pull down other specialties. I mean, they are doing their best job, but family medicine is always challenging. I have felt that without reading every day, it's not possible to practice. Without discussing with others, specialties also every day, without listening with them, without being a part of, the whole entire medical community, it's difficult to practice family medicine. And there was always a question mark as far as I'm concerned. So as I had my ups and downs back in 2010, I did not know what family medicine was. There was nobody to support me. But now the scenario has changed. There are a lot of people around who can help us and help you all residents to show you, to guide you and show you the right way ahead. There are a lot of opportunities coming now. And I would say that, probably at some point of time when you think that, oh, probably I should have taken up internal medicine and I could have become a cardiologist, or I could have taken up some other specialty and done this or done that or made a lot of money. I would say that it is, as I said towards in the conclusion slide, that it is we who are actually closer to the community than anybody else. It is we who actually, hold the hands of the patients, and it is us who actually, make them feel comfortable at home. Having a small baby, who's having high temperature, but they're always comfortable when they have the family physician nearby, at their beck and call. So that is all I have to say. I mean, keep going strong, and wish you all the best. I don't think there's another question. I don't think the minimum time interval between two phlebotomy is default by 1 week, but usually the blood parameters are checked every week, and if the hematocrit is high, we do a phlebotomy. It's not about the phlebotomy; it is about the hematocrits that we are concerned about. So once they come down, then we do it every 2 weeks, and then depending on the hematocrit, we can prolong it further. So if it is not quite high, there are times when in this particular patient itself, when the hematocrit was around 45, and they didn't want to take twice daily medications, I had waited for a month. So, but then by that time it had come to 46. So that is when I put her back on hydroxyurea twice again. So it is all about making sure that your patients don't have any problems. So the intervals, I don't think if it matters a few days here and there.
So I think if there are no more questions, it was an excellent presentation, Ali. Both the first part and the press presentation, very well done. I think we should have more discussions like this and case discussions as well. So everyone can take initiative to conduct such more meetings again. Vishnu?
Thank you, ma'am.
Mamta.
Yeah, thank
Mamta,
you.
just 30 seconds to me before closing. Is it okay?
Thank There's a long list of people who I would want to thank, but 30 seconds I don't think will do any justice. But 2
Yeah,
days
I
back,
know.
I was talking to Rashmi madam, and I
And
was saying like
not
so
Mamta,
many juniors. Hello?
excuse me, Mamta. Ella, I just want 30 seconds before you thank the audience.
Oh, okay. Sorry.
Nothing. Ali, that was a great start for our academic activity. Thank you, Ali, for that nice presentation. I took some time to sensitize this audience to our upcoming national conclave we are hosting here at Kasaragod, Nileshwar. We want all these participants to be there with us during our program, national level program. We are hosting Kerala. Spice Route is hosting the same. We are expecting everyone to be there. We expect everyone to register. Whoever who has not registered till now, please register today or by tomorrow itself, because we want to give the exact number of headcount to book the houseboat. We have arranged everything. We just want to finalize the houseboat. So please book as early as possible. And whoever register through Spice Route, whoever is the eligible member for Spice Route, we are waiving off their registration charges completely by Spice Route Kerala. And others who are interested also can join us. The other FPI members who are interested can also join us. Please contact me or Ali or Vishnu for the same. Thank you, one and all.
When is the event, Nadine?
15th August.
That's on 15th August, madam. From morning 10 a.m. to 4 p.m. at Nileshwaram Houseboat.
Okay.
It's not an academic activity. It's based on fellowship and leadership training program. We are expecting everyone because it's an integral part of an organization to have such meeting. Other than virtual one, we want to assemble as in physical to get more close. Thank you. Thank you, Mamta.
Thank you so much. 2 days back, I was talking to Dr. Rashmi, madam. So I was telling nowadays, many of the juniors are calling us, many of your friends are calling. So they all like the concept of family medicine. They all actually aspire to become a family physician. But many of them have this question like, what are the opportunities we have after family medicine? Like, where can we work? What kind of a clinic or what kind of a hospital will suit you? So there are many questions like that. So I think the whole point of today's session, we had an initial discussion of what to talk on, what topic to select. And I think Dr. Ali has done 100% justice. So first of all, I thank our chair and our presenter, Dr. Ali, for putting up this excellent presentation and for the excellent case presentation also. So you actually depicted how well we can work in a family medicine clinic and how well we can practice what we are preaching also. And I thank our moderator, Dr. Roby, madam, who is always wholeheartedly accepting all our requests and invitations in spite of her busy schedule. Thank you so much, madam. I thank our National Council representatives, Dr. Serin Kuriakos, who is the National Chair, Dr. Jyotika Gupta, National Secretary, and Dr. Kailash P, who is the FM 360 Coordinator, and all others from the National Council who has attended today's session. I extend our heartfelt thanks to our past lead, Dr. Nadeem Abuti, who is always in the upfront, supporting us in all our activities. And we do hope that you continue to aspire us and support us in all our future activities as well. I thank all my respected seniors and teachers, Dr. Rashmi madam, Dr. Vijay Raj, Dr. Zarin, Dr. Shehzad, and if I have missed out any names, ask apologies for that. And my fellow colleagues, Dr. Vishnu, Dr. Anuna, Dr. Nikesh, and thank you each and everyone who was present here for today's topic. And I just want to add one more point that we are planning to conduct academic sessions every month. And we want a continuing medical education to happen. And more institutions, now there are many institutions who are doing MD and DNB family medicine all over Kerala. So it will be a platform for many junior residents as well as senior residents. They can also take topics and case presentations. So I wholeheartedly request all your participations in all our future activities. And if there are more takers, we'll have twice a month also. So our next session is planned on August 5th. So the first taker will be Teams Trivandrum. They are planning to do a case presentation. So the details of which will follow. So thank you all for the active participation. See you on the next session. Thank you.
Thank you all.